Shall we start? Okay. So coming to the second topic, that is, so coming to the approach to urticaria and angioedema. So before we go to urticaria and angioedema, these are basically dermatological conditions, but this is also, kind of presentations that come to your medicine OPD. The patient doesn't know, right? If a patient is having a skin symptoms associated with an increased cough, an increased systemic manifestation, like a sometimes a laryngeal edema, change in voice, sometimes your diarrhea can occur, sometimes your GI manifestations can occur. The patient would come to a general medicine physician. So obviously you should know how to manage a possible urticaria, at least know the approach before you kind of say that this is a purely dermatological condition and refer him to the dermatologist. So types of hypersensitivity is something that you know: type 1, type 2, type 3. So type 1 is basically is something that we are going to deal with. It's basically your IgE mediated hyper sensitivity. Type 2 is your antibody mediated. Either the antibody will directly go kill the particular cell or via complement cause these actions. Type 3 is your antigen antibody complex mediated hypersensitivity, and type 4 is your cell mediated hypersensitivity. So 2, 3, 4 we are not going to touch here, but it is mainly the type 1 hypersensitivity that usually leads to urticaria. So what happens here is your involvement of your Th2 cells and IgE class switching in your B cells. So these are triggered by any of the allergen. It can be pollen, it can be some food, it can be some insect. All of these can trigger this particular change in your cells, that is your B cells and Th2 cells, leading to the production of IgE. So the main kingmaker of this particular reaction is your IgE. So those IgE will come bind to the mast cell on the surface. So this surface has this Fc epsilon R1 receptors for IgE, and this after binding, there is the Fc portion of this IgE will cross link. So once the Fc portion, that is the base of the IgE, these will cross-link, and once that cross-linking occurs, there is mast cell degranulation. So once this mast cell degranulation occurs, again this happens after the second exposure, that is a re-exposure. At the first exposure, this is the mast cell surface, just cross-linking will happen. Once there is repeat exposure, that particular antigen will come, and this particular signal transduction will happen downstream, and this downstream signal transduction will lead to mast cell degranulation. So once mast cell degranulation happens, these various mediators are released. These mediators will cause a reaction, that is your immediate hypersensitivity reaction. But these mediators will not just cause a reaction, they will also cause other cells to come to that site, and those other cells, that is your basically cytokine action, will cause a late phase reaction. So early phase is basically your degranulation leading to various factors, while your late phase is because of these factors only, but because of your cells coming to that particular area. Those cells again via various other factors will cause changes, but they will be slightly different to the early changes that are there. That is your early phase that is there. Especially your eosinophils are your major cell infiltration that occurs in the late phase. So these are your various mediators leading to various changes that happen. I'm not going to the details here. Predominantly it is general allergic manifestation, and your various broncho constriction, all of those vasodilation, all of that changes will happen. So whether it be early or late, via various mediators, these changes are caused. So clinically, what are the types? So you obviously know anaphylaxis that happens very commonly in your various as an infusion reaction. Then there is wheal and flare. This is what we are going to kind of look at in this particular discussion. That is your urticaria and angioedema. It can be allergic rhinitis, asthma, food allergy. All of this can happen, and mainly we're going to look at this wheal and flare reaction. So what is urticaria? So urticaria derives itself from this particular plant, that is Urtica dioica, and this is basically also called your stinging metal. So it's basically from the name itself that it causes severe itchy reaction in your skin. So urticaria is basically impaling of your skin by these, with the formation of these wheals and flares, and also there are various biochemical irritants that are there in this plant, which also lead to direct urticaria possibility. So urticaria is basically a vaso reaction that occurs, a hypersensitivity of the vascular wall that occurs because of various mediators leading to a particular phenotype. So this is, it's not exactly presentation. Something like a formation of these wheals is not called urticaria. There can be urticaria without wheals also, but the basic definition is your hyperreactivity by these blood vessels to your various agents. So it's an intensely pruritic urticarial plaque with or without wheals. This is what I can tell you. And how is it different from angioedema? So angioedema is basically a deeper reaction, right? So it's deeper, less well defined. It is more of a pain rather than itching. It's less erythematous, and main thing is your deeper tissue is what you should remember, and it takes longer to resolve. It's slightly more severe and deeper is what you can remember. So this is how these classic urticarial lesions look like, and these are what are called wheals. So these are extremely itchy pruritic lesions that are there, and these are well circumscribed lesions. In angioedema, it's not as well circumscribed. In your pure urticaria, it is well circumscribed, and also it is non-petting edema with blanched corners. So this is what happens. So well circumscribed areas of non-petting edema with blanched corners, and also the raised borders that are there, they involve not only the superficial involve only the superficial portion of the dermis, and the deeper part of the dermis, if it is involved, then we call it as angioedema. And also whenever there is this blanched centers, there is erythematous corners of these particular lesions that are there. So historically, we have been reading through our physiology. This is the triple response of Lewis. That is, initially there is redness as a result of a capillary dilatation caused by increased blood flow. Then there is flare. So this is what is called wheal, red, flare, and wheal. So don't remember as wheal and flare being, in chronological order. It's actually red, flare, and wheal, right? So first the redness occurs because of capillary vasodilation. Then the flare occurs, that is in the form of itching and redness because of the arteriolar dilatation to axon reflex. And finally, there is wheal caused by extracellular fluid exudation leading to a swelling that occurs with, basically the swelling is at the center, and there is reflex erythema that happens in the periphery. So central swelling of variable size and reflex erythema happens at the periphery. This is what is a different, more deep and more, painful lesion, that is angioedema. This is involving the lower part of the dermis and subcutaneous and the mucous membranes, and itch is less predominant, pain is more predominant, and resolution is much slower. So this is a basic classification of your urticaria, acute versus chronic. Acute is 6 weeks, more than that is chronic. And also depending on the etiology, it is divided into inducible and spontaneous. So inducible is something that we've been reading through our MBBS. Various types of inducible urticaria are there, but if it is spontaneous, this is where an immunologist or a general medicine physician is consulted for by a dermatologist to kind of help in finding out an underlying possible systemic illness leading to spontaneous chronic urticaria. So spontaneous chronic urticaria patients are what are usually referred by the dermatologist to medicine to kind of rule out an underlying systemic cause. So these are the various causes of acute spontaneous urticaria. So this is what I was telling you, right? Acute spontaneous urticaria. And again, do not try to go into the depths. You can remember the list if you want to for your residency exam, but there can be anything that can cause an acute spontaneous urticaria. Either it can be allergic, that is your type 1 hypersensitivity causes, or non-allergic. These are your kind of non-type 1 hypersensitivity causes which can directly release your histamine, and that can also cause your acute spontaneous urticaria. While chronic urticaria, either it can be inducible where there is an identified trigger, or your chronic spontaneous urticaria which is referred. And again, that is also divided by whether if there are only wheals plus angioedema, or angioedema only. So this portion we will come to later. This portion we will see later. For now, you just remember chronic urticaria is chronic inducible or spontaneous. So inducible, we know, can be solar, it can be because of exercise like cholinergic urticaria, can be because of some, temperature changes like cold, pressure, vibration, contact, aquagenic, just water. All of these can lead to chronic inducible urticaria. So now coming to the most important part, that is the chronic spontaneous urticaria. Again, this can again be idiopathic. So once you ruled out all your causes, either autoimmunity, infections, food allergies, drugs, emotional stresses, all of these you ruled out, you kind of say that it is idiopathic urticaria. So even if the dermatologist is referring to you, more often than not, you will kind of end up with this etiology, with this particular diagnosis, that is your idiopathic chronic spontaneous urticaria. So this is your kind of diagnosis that basically says that, okay, this patient is having urticaria, but we have gone through our possible inducible causes, your acute causes, possible various etiologies of chronic spontaneous urticaria also, but still there is no diagnosis, then you call it as idiopathic CSU. So comorbidities are something that are associated with most autoimmune conditions like your hypothyroidism, like Hashimoto thyroiditis, Graves. All of these are something that are associated with most autoimmune disorders that are there. So these are various history and physical examination that you should do when a patient comes. So time, basically acute versus chronic, shape, size, frequency, duration, all of these are something that you would definitely take in your history. And also you would look for possible underlying triggers, whether it be drugs, whether it be some travel that the patient might have done, whether it be some underlying infection that might be there. And also you will look for, possible other triggers like food allergy, all of that you will look for and kind of zero in on a possible trigger that is there. Then we come to mast cell independent urticaria. So whenever I told you about urticaria, just remember that urticaria is not always because of this classic type 1 hypersensitivity. So type 1 hypersensitivity, which we talked about, that is one of the most classical, one of the most important forms of urticaria, one of the most important pathways of urticaria. But what did I tell you? Whatever this particular cytokines, these histamines, these particular bradykinin, whatever these mediators are there, these mediators may either come from the mast cell or they can come from some other area, right? So if they come from the mast cell, well and good. These are predominantly histamine based. So histamine is something that is very classically associated with mast cells. So these are mast cell mediated urticaria. So this is your mast cell mediated urticaria. But if ever these mediators are being released from somewhere else, these mediators are released from either your normal pathways or because of directly from chemicals itself, those chemicals coming and triggering these release of these mediators, then they will be non-mast cell mediated, non-histamine mediated urticaria. So what is the main phenotypic difference between your mast cell mediated versus non-mast cell mediated? So why are we getting there? Because here there is a classic phenotypic difference. So mast cell, remember it like this. So mast cell histamine will lead to wheel. So just how I remember is M is not equal to W, right? So these are two opposite letters, opposite looking letters, and this kind of looks like a H, right? So mast cell, histamine, and wheel. So mast cell, histamine, and wheel go together more often than not. There's only one exception to this rule that I will tell you, but usually these three things will go together. Mast cell via histamine will cause wheel. So whenever somebody is saying mast cell independent urticaria, that basically means histamine is not being released. So this may be bradykinin mediated. Bradykinin is the second most important mediator which is leading to urticaria. So this bradykinin mediated urticaria, which we'll discuss in a little bit detail ahead, can either be due to C1 estrase inhibitor deficiency, which again can either be due to hereditary causes or acquired causes, or it can be due to ACE inhibitor induced urticaria. That is, bradykinin can, because of various causes which we saw, either C1 inhibitor deficiency or ACE inhibitor induced urticaria, can lead to this mast cell independent urticaria. So other thing which I told you is vasoactive stimuli. So whenever there is some weird stimuli that is there, they can also directly lead to formation of various mediators independent of the mast cell, and they also can lead to your urticarial lesion. So basically, direct vasodilation and increased permeability occurs without mast cell involvement. So this is what I was telling you about your bradykinin. So this is histamine mediated, right? So histamine mediated, family history of atopy will be there, wheals will be there, urticaria will be there, idiopathic disease will be there, and allergy and other atopic kind of features will be there, and this will lead to IgE mediated degranulation leading to histamine primarily, and along with various other mediators leading to urticaria as well as angioedema. Now we come to bradykinin. So this is one pathway that I know that you would have read associated with your ACE inhibitor cuff in our pharmacology. Whenever we read ACE inhibitor induced cuff, we definitely go through this. So the main thing you have to remember is kallikrein basically converts your high molecular weight kininogen to bradykinin. If you remember this particular central pathway, then you can remember what is above it and what is below it. So this is your main box that you should remember. Kallikrein converts high molecular weight kininogen to bradykinin, and bradykinin will bind to your various receptor, bradykinin receptor 2, and lead to various changes of your angioedema, and possibly kind of a severe anaphylactic possibility also can happen there. So bradykinin is usually degraded by another mechanism. You don't need to remember the mechanism and all, but the one very important enzyme that is there, that is your SL, angiotensin converting enzyme. So ACE, and also these are also important if you remember your cardiology drugs, your neprilysin inhibitors, all of that are also there. So neutral endopeptidase, aminopeptidase, carboxypeptidase, all of these are also something that basically break down your bradykinin. So when you give your ACE inhibitor, this breakdown of bradykinin is not happening. Bradykinin is increasing, going binding to this BK2, and this will cause again bradykinin-induced changes. So drug-induced angioedema is due to inhibition of bradykinin degradation. It can be due to this vilagliptin, beta-gliptin also, because DPP4, that is your dipeptidyl peptidase 4, that is also something that breaks down bradykinin. So DPP4 inhibitors, sacubitril and enalapril, all of these will increase bradykinin, lead to bradykinin mediated changes. So this is one particular area that you have to know, that is your degradation pathway is inhibited by certain drugs and they will cause bradykinin mediated angioedema. Then we come above, right? So this is your C1 activation. So whenever C1 activation is there, then that will increase your plasminogen to plasmin conversion and your via your factor 12. Via your factor 12 and your plasminogen to plasmin conversion, C1 activation will convert prekallikrein to kallikrein, and kallikrein, you know what it does? It will convert high molecular weight kininogen to bradykinin. So once C1 is there and C1 esterase, which is your main enzyme, which is converting, increasing this pathway, these both are there, C1 and C1 esterase, this whole bradykinin formation increases. So to prevent this continuous formation, you have something in your body that is your C1 esterase inhibitor. Sometimes it's just written as C1 inhibitor, but it is mainly your C1 esterase inhibitor. Esterase is basically something that increases your C1 activation. So because of the C1 esterase inhibitor, this whole pathway is kind of toned down. But whenever there is C1 esterase inhibitor deficiency, what happens? C1 esterase inhibitor deficiency. C1 esterase inhibitor is not inhibitor is not there. C1 esterase increases, whole of this pathway increases, bradykinin increases. So whenever this C1 esterase inhibitor deficiency is there, this whole bradykinin induced angioedema increases. That is what is the main thing that is there. So how this C1 esterase inhibitor is deficient is also something that we should look for. This is basically essentially the same thing. The only thing that I wanted to kind of add on are your various drugs. You can use various C1 inhibitors to block this pathway, like your ecallantide, etc. You can use icatibant, which is basically your bradykinin receptor antagonist, or you can even use tranexamic acid. Tranexamic acid is something that we know at the plasminogen to plasmin level it acts, and that also can be used to kind of suppress this pathway and decrease bradykinin mediated angioedema. So this is something that you have to remember. How I usually remember is your bradykinin mediated angioedema is slightly more, sinister, in the sense abdominal attacks, laryngeal attacks, oropharyngeal attacks. Oropharynx and tongue is associated together, right? So these three things, which are basically your even your genital involvement, these three four things are slightly on the more severe end of spectrum, and these are associated with your bradykinin mediated angioedema. While your itching, urticaria is kind of a weird one, because sometimes what is written in books is your bradykinin mediated angioedema is also written as bradykinin mediated urticaria also, but more often this is discussed in the sense of bradykinin mediated angioedema, because that here, as you saw, right, it's mast cell independent urticaria, but better word is angioedema, because angioedema is the one that usually presents. If it is there is involvement of histamine, it will usually present as urticaria or wheals. So okay, let that aside. The main thing you should remember is this one, that is bradykinin mediated. There will be genital involvement, there will be abdominal involvement, and there will be possible oropharyngeal laryngeal involvement with a tongue involvement. But histamine mediated or mast cell mediated, there will obviously be wheals, that will be itching or urticaria, and earlobe involvement or ear involvement is also there. So this is what is it is. So angioedema without wheals, or basically your non-mast cell mediated, is usually always non-histamine mediated, but there is one exception that I told you about. In acquired cases, if there is no identified cause, sometimes there may be response to antihistaminics. Usually there is no response to antihistaminics if it is bradykinin mediated angioedema, because there is no histamine involvement. Why will it respond to his antihistaminics? But there is certain there is a certain condition that is idiopathic histaminergic acquired angioedema without wheals that is usually responsive to antihistaminics. So this basically means that even if there are no wheals, once you can give antihistaminics and try. If it doesn't work, then okay, you can say that it is some bradykinin mediated, but you should usually give antihistaminics and try. Next, others are ACE inhibitor treatment. If it is there, just remove the ACE inhibitors. It is related to ACE inhibitor induced angioedema. Then C1 esterase inhibitor deficiency, that we will come to what it means, right? So bradykinin mediated angioedema, these are your main 3-4 drugs. So this is your lanidolumab, which is basically your monoclonal anti-plasma kallikrein antibody. Then you have icatibant, which is basically your bradykinin 2 receptor antagonist. Then you have ecallantide, which is your kallikrein inhibitor, and your explainable tacroic acid, that is your tranexamic acid, which is also useful in your plasmin to plasminogen breakdown. So this is your most important slide here. So this is your C1 esterase inhibitor kind of abnormalities that occur. So this is your hereditary angioedema type. So what is hereditary angioedema? It is basically your abnormal pathways associated with these leading to your increased bradykinin mediated angioedema. If it is type 1, it is basically decreased C1 esterase inhibitor level. This is the most common type of hereditary angioedema where C1 esterase inhibitor is gone, C1 esterase is increasing, directed increased pathway of that occurs, increased bradykinin occurs, and all of that will lead to increased bradykinin mediated angioedema. Another thing is the amount of that enzyme is normal, but it is dysfunctional. This is usually due to mutation in SERPING1 gene, and this will again lead to increased bradykinin formation. Very rarely there can be normal pathway in the sense of this whole bradykinin area. There will be normal C1 esterase inhibitor levels and there will be normal function of the C1 esterase inhibitor, but the pathway will be defective in the sense it can be either the factor 12, it can be either the prekallikrein, kallikrein, it can be the high molecular weight kininogen. All of these kind of things that are being mutated, that is plasminogen, angiopoietin, kallikrein, all of these molecules are mutated, then also there will be increased bradykinin formation, and that can also lead to a type of hereditary angioedema, although it is quite rare. So with this, we see mainly your two types of urticaria or angioedema. One is that occurring via the histamine, one is via bradykinin. And via bradykinin pathway, the very important pathology that you should kind of keep an eye on is your hereditary angioedema. Now this is slightly in depth. So what happens usually is whenever there is C1 activation, right? So we looked at C1 activation, which is a trigger point for your whole bradykinin pathway, right? So here we looked at C1 activation. Whenever C1 is activated, if you remember the complement pathway, there is increased C4 activation as well, and this leads to decreased C4 level. So whenever there is C1 activation, there is classical pathway of complement that is triggered, and that leads to decreased C4 level. So whenever C4 levels are decreased, then so firstly, what we do as a usual testing, when we usually test for complements, you know what we test for? C3, C4, right? So whenever you have a patient with angioedema, you do C3, C4 levels, you see C4 is low. You don't directly do C1 levels. C1 levels, C1Q levels, those are slightly high level testing. You usually do C3, C4. Once you see that C4 is low, what do you think? That there is some C1 activation happening because of which C4 is low. So if C4 is normal, then it is unlikely. It is unlikely that the whole bradykinin pathway is getting activated. If C4 is low, then you can say, okay, C1 pathway is getting activated. But however, if you see the levels of C1 esterase inhibitor and you see that the C1 esterase inhibitor levels are normal, then what do you get to? You get to these two conditions, that is your type 2 and type 3. That is either the functioning of that C1 esterase inhibitor is abnormal or that pathway is abnormal, that is your factor 12 kallikrein, all that pathway is abnormal. There, how you can differentiate? By seeing the function. If the function is decreased, it is type 2. If the function is normal, it is type 3, as simple as that. Then you also see C1 esterase inhibitor levels to be decreased. That is your type 1 hereditary angioedema, or here I add on another thing, that is acquired angioedema. So you don't need to get into this, but if at all acquired angioedema you are seeing, this is usually something like SLE that causes acquired angioedema via C1Q and increase C4 activation, etc. Here you measure C1Q levels. So if C1Q levels are increased, that is acquired angioedema. C1Q levels are normal, then it is hereditary angioedema, as simple as that. Then we quickly go through some possible differentials or syndromes that are presenting with wheals or angioedema. So urticarial vasculitis is something that presents. This is with an associated underlying vasculitis. It is more painful than compared to just pruritic angioedema, and there will be associated systemic features like a fever, arthralgias, something that can happen in a primary systemic vasculitis, and also there will be residual purpura and long-lasting lesions will be there. And this is something that is there as a chapter in your Harrison's in your immunology, that is your urticaria pigmentosa or mastocytosis. So here, this is also a popular NEET PG question, that is your Derriere sign, which is usually seen in mastocytosis, which is basically when you stroke the skin, then you will get a urticarial reaction, which is your Derriere sign that is there. And in general, it is usually reddish brown macules and papules. Then ACE inhibitor or bradykinin angioedema, which we already discussed, it can be either hereditary or ACE inhibitor, depending on whether there is drug intake history or not. Bullous pemphigoid is a dermatological condition. You don't need to know much about it, but just remember that it's a usually elderly patient with more often a blistering manifestation that occurs. But before the blisters actually develop, it can kind of resemble a angioedema or just a urticarial lesion. Autoinflammatory syndromes, I hope you have seen the lecture on autoinflammatory syndrome. This usually presents as urticaria, especially the cryopyrinopathy. So the cryopyrinopathies, that is your Muckle wells, that is your FSAS, that is your familial cold autoinflammatory syndrome, your even your SINCA or NOMID, neonatal onset multisystem inflammatory disease, all of these will present with cold-induced urticaria, as well as your Schnitzler syndrome and Muckle wells as well, which we already talked about. Usually it is since birth, predominantly involving the trunk. There is no flare surrounding the wheels, and various systemic manifestations that are seen in your autoinflammatory syndromes, predominantly periodic fever, etc., are seen. So if it is acute urticaria, you don't need to work up. You basically need to treat them with antihistaminics and see, and if there is a possible trigger, you have to keep them out. If it is chronic urticaria, especially if it is spontaneous urticaria, then you should look for various other differentials. You should check for comorbidities that we discussed, like hypothyroidism, etc. And you should look for various predictors of bad prognosis. So basically, do your routine lab tests and do an extended diagnostic workup. If there is, based on history, if there is certain triggers, etc., you can rule out those triggers, and also you will rule out various associated conditions. For example, mastocytosis, you will do serum tryptase levels. For associated hypothyroidism, you will do thyroid hormones, all of these, allergic testing, infectious testing, functional auto antibody testing like autologous serum skin test. All of this also you will do. Management, apart from your kind of avoidance of your triggering factors, other thing is tolerance induction that can be given. If you know the trigger, you can slowly give slow small amounts to kind of enhance tolerance to that particular agent. And pharmacological treatment is involving your various mediators of your allergy. So allergic mediators, we already know, if it is an acute response, it usually is associated with your acetylcholine, whether it be your muscarinic antagonists or your phosphodiesterase. Again, phosphodiesterase is also something that is breaking down your acetylcholine mediator, that is your cyclic AMP. All of these are your acute response agents, which are basically beta agonist, muscarinic antagonist, PD4 inhibitors, all of this that is there. And if it is chronic response, then it is something like a steroid, something like a leukotriene blockers. All of these are your chronic response actions. But at the level of your mast cell, the main thing that you should remember is your anti-IgE monoclonal therapy, because we'll be looking at it in your refractory chronic spontaneous urticaria. Then you will have to use this treatment, that is your anti-IgE monoclonal therapy, that is your omalizumab, that is there. In your pharmacological therapy, your second generation antihistaminics are your first line agents, and they will basically target your mast cell mediators, that is your histamine. So second generation, you would know the various uh, drugs that are there: cetirizine, levocetirizine, estimazole. Or estimazole, again, it's kind of banned now, but most of these like loratadine, rupatadine, all of these are very good drugs. Levocetirizine, pitotifen, obviously these are basic drugs that are there. While your first generation, which is not your first line drug for your urticaria, they are like chlorpheniramine, diphenhydramine, hydroxyzine. All of these are also used. So basically, you obviously know these basics, right? Sedation will be more in your first generation because of the crossing of blood-brain barrier, and your muscarinic adrenergic action also will be more in your first generation. Selectivity will be more in your second generation. All of this you know very well. So in your liver disease, kidney disease, this is something that will usually might not see, just remember, if it is liver disease, then first generation is to be avoided. If it is kidney disease, then safer is the first generation, and second generation will need dose adjustment. So liver disease, second generation better, and in your kidney disease, first generation is better. So these are your Indian guidelines. This is basically what is followed all over the world also, although there here and there are certain guideline changes. So first, first measure is to avoid triggers. Second measure is to add second generation antihistaminics. If non-responsive, increase the dose of the second generation antihistaminics. If still not working, then you go to your immunosuppressants. You start with corticosteroids, very short dose. If that is also not working, then you go to steroid sparing agents like cyclosporin has the strongest evidence, and also you can consider methotrexate, doxepin as well. Also, omalizumab is something that works very well in your refractory cases. So basically, second, avoidance of triggers, second generation antihistaminics, then you go for steroids and your steroid sparer. This is how basically the treatment is. So acute angioedema treatment is essentially largely the same, but here your using of your corticosteroids is more commonly recommended, and also sometimes it can lead to your emergency as well. And there also you would kind of have your anaphylactic measures as your basic. So H2 antihistaminics, very low evidence, firm recommendations are lacking. But this again, this is with respect to your fields with angioedema, right? So and also here, also remember that most of these agents do not have very strong RCTs, but we kind of have formulated our own algorithm for treatment. So neither do leukotriene modifiers nor do systemic corticosteroid. Nothing has very good RCTs, but they are how the treatment algorithm goes. So first, second generation antihistaminics, leukotriene modifiers, and systemic corticosteroids, especially in acute cases where we use a short course of oral steroids. Chronic refractory urticaria, as I told you, 6 months disease duration, not controlled, with increased antihistaminic dose up to fourfold dosage given for at least 3 consecutive months, and requiring repeated oral steroids. So these are the main agents that we use in your chronic refractory urticaria after 6 month duration, 3 months of treatment of antihistaminic, and repeated requirement of steroids. That is omalizumab, which is actually quite costly. And these are the side effects that are there. Main thing that has been asked is your upper respiratory infections that can occur. And it can bind to free IgE, it can bind to bound IgE, decreases expression of high affinity receptors of IgE, decreases mediator release by the mast cells, and all of these lead to decreased allergic inflammation, which is the basic mechanism of action of omalizumab. Also, there is other monoclonal antibodies like your ligelizumab. This is your novel monoclonal antibody by binding to C epsilon 3 domain of the IgE and preventing the interaction with Fc epsilon R1. Culizumab, which is your IgG1 antibody that binds to membrane bound IgE on the B cells at the M1 prime segment. This basically, you don't need to remember, all of these are types of anti-IgE monoclonal antibodies used in refractory chronic urticaria. These are your various immunosuppressions, where the highest kind of evidence is for cyclosporin, followed by azathioprine and methotrexate. No need to remember the doses, etc. It's usually whatever we give at usual mild immunosuppressive doses only. So in case of delayed pressure urticaria or urticarial vasculitis, you end up using steroids whenever, and even dapsone you use in these two conditions. In your hereditary angioedema, you basically target that whole bradykinin pathway with tranexamic acid and your aromatase inhibitors. In your familial cold urticaria, which is your autoinflammatory syndromes, here you use your IL-1 blocking agents. Autologous serum therapy is basically you take urine therapy and you take a serum which is having a tolerance filled particular response to a trigger, right? So you use that serum and give it into your own body. You take the serum, kind of show that particular antigen to that serum so that tolerance will develop, and then that serum is given to your own body via IM or subcutaneous route. Again, here mixed reports are there, but just remember that in urticaria, in severe refractory urticaria, autologous serum therapy is also an option. So this is basically just to write in your, this is not something that is usually used as a prognostic marker, but in your exam, if you're writing a long answer, definitely write this prognostic markers. That is your late onset, multiple episodes, associated angioedema, relapsing remitting. All of these are basically showing that it is not responding to your second generation antihistaminics, and also age will be more. So these are basically associations with your poor prognosis. So concluding, this is a clinical diagnosis. It's extensive workup is not needed unless you want to rule out various manifestations. Mostly treatment is not required. Acute spontaneous response will be there to second generation antihistaminics, and if at all there is requirement of other agents, then you should kind of rule out other underlying causes. So with this, we complete this kind of short topic, that is approach to urticaria and angioedema. The main thing that are usually asked in your exams is your various types of urticaria. You need to remember that particular flow chart of the types. And second is your hereditary acquired angioedema, hereditary versus acquired, and the types of hereditary angioedema. These three, four things are the main things that are focused on.